Hi everyone, my name is Tobias Mattei. I'm the deputy editor of the North American Spine Society Journal, and I have the pleasure of having with me here today Dr. William Schnapp. He's the first author of a study entitled Basivertebral Nerve Ablation for the Treatment of Chronic Low Back Pain in a Community Practice Setting, a 6-month follow-up. The study has recently published in NASSJ, and I have the pleasure of having Dr. Schnapp with me today. Thanks for your time.
Thank you. Good morning. Thank you for having me, and thank you for your interest.
So would you like to perhaps introduce yourself, maybe a little bit of your practice, your training, and the rationale for this study? I understand that this is the first independent study on the effects of basivertebral nerve ablation besides the trial, the INTERCEPT trial, which validated this technique and was used for FDA approval. So please.
Yes. My background is in neurology, and then I did a fellowship in pain medicine at the University of Miami. I'm in private practice. I work with 2 orthopedic spine surgeons and a physiatrist, so it's 4 of us, four MDs in our practice. And the rationale for the treatment was that we really wanted to see if this worked in our hands, in our real world setting. This was quite an extraordinary claim regarding the ability to treat pain at this level, treat end plate pain in this way. And so when I found out about the original studies, the 2 level 1 studies, I really wanted to see if this would work for us. And so we really just wanted to keep track of our own patients, our own outcomes, and then ultimately make that information available so that others could see, what we found.
Perfect. Would you like to summarize some of the results of your study? It was a very well-performed study, even though with a low sample, but you used several standard patient-reported outcome measures, pretty similar to what was used in the initial INTERCEPT trial. So that helps also with a comparative analysis with their results, but please give our listeners some idea of what your findings were.
Sure. So this was 16 patients that we followed. We have to date enrolled 47 patients, so we're hoping to publish a larger cohort at a later date. But what we found was statistically significant improvements in both the ODI and visual analog scale at the time points 1, 3, and 6 months. They were above the minimal clinical important difference. And at 6 months, we saw about a 26-point improvement in the ODI, which we found quite significant.
What is it? And I'm curious about the methodology because there's one table that you report the levels which were performing, and I understand one of the inclusion criteria were modic changes, which makes sense in terms of the therapeutic mechanism that is expected for this type of procedure. But there were a few cases that you did only one vertebra, and I suppose those are quite rare instances where you have modic changes, for example, in the superior end plate, but not in the adjacent inferior end plate. But can you clarify what those patients, what MRI findings those patients had?
Sure. So in the cases where we did one level, it was typically where there had been a fusion and there was an instrumented level that we could not access. And so we were able to access the adjacent level. And so typically where we would do one level, you're right, you would expect 2 levels on the side of each disc. However, where there's a fusion, that might not be possible.
Oh, I understand. So let's go a little bit and discuss about the meaning of your results. I've been following the data on basivertebral nerve ablation, and for me, it makes sense in terms of the pathophysiology. We've been focused on discogenic pain or pain emanating from the disc for the past few decades, and none of the techniques that I remember seeing, for example, during my early trainings, like IDET or Ablation. I don't know if you remember that, and there was a big push until I think 2005. That was, I think, was the first double-blind trial, randomized trial that I've seen in spine surgery, because it's pretty hard to blind a surgeon for any type of intervention. But basically, they turn off the radiofrequency ablation system at that trial, and they saw no difference between the coblation and the sham procedure in 6 months. And I think since then, I've not heard of coblation or IDIT being performed, and most insurance nowadays do not approve. So I like the idea and the concept of targeting the what most people call vertebrogenic pain. But one concern that I have, and maybe you can give me some insight into this, is that, for example, I found in your study, for example, in 6 months that you had, just focusing on ODI, you had an improvement of 21.1% in your study. So that's above the MCID, which is, I think, 15 for what you brought in the literature. But if you go to the initial INTERCEPT study that was used for FDA approval, it showed that the placebo group had an improvement of 15.2%, 50.2 points in the ODI, while the treatment group had 20.5. So it means that both at 1 month, 3 months, and almost at 6 months, your improvement was very similar to what the placebo treatment had in the initial trial. And then at 6 months, it kind of jumped to closer what the treatment was. So my problem when I see things like that is that if you had such a significant improvement in the ODI in the placebo treatment, how easy is to differentiate a procedure that is truly effective from one that there's a significant placebo effect, or maybe we're not selecting the patients well, and there's the heterogeneity of the sample explain those findings. But if you'd like to give me your comments on the possible placebo effect which might be involved in your procedure or in your study, and of course it's not accounted because it's not a randomized study.
Yes, absolutely. So this was not a controlled study. This was done in a real-world setting, and I think the placebo effect is always going to be a factor. There may be patients who might give us a few points, let's say on the ODI, because they like us or because they had a good experience, for example. So because this is not controlled, this in no way should be compared. The results cannot be directly compared with the results of the randomized controlled trial. I would assume that there would be a placebo effect in most treatments done, especially when we're talking about pain. Pain is very difficult to measure, to quantify, and makes it exceedingly difficult to study. So you're right. I think what we wanted to see was, gosh, do patients get better? What if the results had been that no patients got better or patients got worse? We at the very least wanted and hoped to see that that patients got better. But your point is well taken.
Yeah, and I agree with that. For example, that study we mentioned about the IDIT, it was such a big blow on the technique because not even the placebo study had any improvement at 6 months, and neither had the IDIT. So I think the fact that you had some improvement suggests that there may be a real effect. But I think the great question when we're evaluating this type of procedures is, how invasive the procedure is. In this case, for example, you're going through the pedicle, you're not even puncturing the disc space like a discography or annuloplasty, which we know leads to disc degeneration. So, the deleterious effect of the procedure itself could be said that are not substantial. But I believe the great question when we analyze the literature and evaluate the MCID values is how willing are we to be indicating a procedure that may not be effective, or what is the threshold, taking account the low invasiveness of the procedure and the fact that this is a population of patients with refractory pain for whom there's not many alternatives. And I go back to the INTERCEPT study. I think they reported in terms of, I think they set a threshold for ODI of greater than 10, and then they found a significant difference between the treatment and the placebo group. But 75.6% of the treatment group had an improvement of more than 10 points. But notably, 55.3% of the placebo group had an improvement of more than 10 points. So that means that, yes, there was a meaningful difference, but more than half of the placebo group had an improvement of greater than 10 of ODI. So that just tells me that, okay, 10 points in the ODI is not something that even the insurance would be willing to pay, or in terms of cost effectiveness, the threshold should be higher, because you don't want to have, I mean, it's too much for improvement for a placebo treatment. 55% improvement on the placebo treatment is too much. We need to be more selective on that. And I don't know, what are your thoughts in terms of evaluating? I know that in your practice, as much as in mine, there are some patients that you have just exhausted most options. And in my case, I do dorsal column stimulation system for this type of patients that have failed conservative treatment and injections and facet ablations and all these interventional procedures. But usually the paradigm that most surgeons follow is that you try all interventional pain procedures, and if you're still failed, then yes, you may be a candidate for a trial with a dorsal column stimulation system. So, I mean, to be honest, I would be more than willing to accept a low level of confidence, or let's say some degree of placebo effect in this procedure, taking into account the challenging which is treating this type of patients, and the fact that you're almost at the end of the line in terms of the resources, therapeutic resources you have. But give me your thoughts in terms of the population you see. What is your thought process? When do you indicate this? Do you try all the facet ablations and all the other things first? Or if you see a modic change, maybe this is the first choice for that population? Give me your paradigm.
Sure. And your points are all very well taken. I can tell you that this is not, so far in our practice, been a first option for patients. It might have been a second option, or it might have been a third option. And we certainly encounter a lot of patients with very challenging types of pain, with difficult to identify pain generators. What I can tell you is that we do a very thorough examination, and we're really selecting patients with symptoms of anterior column pain. In other words, these are patients with mechanical, non-radiating axial lumbar pain. And so the pain generators in that situation are limited in numbers. So if they've tried a facet block, and many of them have, they've tried an RFA, they have not gotten improvement. That leaves only a couple other options for them before considering other major interventions, such as an open lumbar surgery, for example. So yes, it's a procedure with a very good safety profile. It is more invasive than a facet RFA, but far less invasive than many other kinds of lumbar interventions. But I would say that in our practice, we first lead with a good history and physical examination, and they really need to have mechanical type axial lumbar pain. These are older patients that we have treated. They're in their 6th, 7th, 8th decades. They might have pain in all three planes of motion. However, we really try to find patients that have, in whole or in part, pain on forward flexion, where there's an indication that the anterior column is in play.
And what are the criteria that you use for that? I mean, one, of course, is modic changes. I mean, like you mentioned, the pain with flexion. Have you used the discography for these patients, or have you?
I have not. I have not. I don't typically do discography for our patients, and for some of the reasons that you mentioned earlier. And then the question about what to do with that information is also not clear.
Correct.
So
it is my impression in terms of discography. I remember it was a quite widespread procedure maybe a decade ago. And Eugene Karaji, who was the previous editor of the TSJ, he was probably the greatest expert in terms of discogenic pain and studying discography. And I mean, he published several studies demonstrating that the long-term effects of discography are not that benign. And we know that because in terms of experimental models for discogenic pain, I mean, we usually, if you have a rat model and you want to induce this degeneration, you puncture the disc with the needle. So, I mean, if you're doing discography and you're injecting contrast to the point that you're seeing the contrast disrupting significantly the annulus and to cause the pain, and you do that at 2 or 3 levels, some of which may not be causing pain, I mean, definitely it's not a benign procedure that you can tell that you're not affecting the natural history of disease. So I agree with you. I mean, in my practice, I've not used it, and honestly, I've not seen many pain managements using in the past few years. So, and I'm just saying that because I still think we lack a validated test for proper diagnosis of anterior column pain, and that would encompass both what we used to call discogenic pain and more recently what people have called vertebrogenic pain. And to be honest, it's probably a combination of both, but it's definitely different from, for example, facet-mediated pain.
Yeah, I agree. Now, I would love to have a series of different tests. For example, when we evaluate the sacroiliac joint, where we have 4 or 5 different tests where we can evaluate that joint. It's difficult, really. You're limited to, okay, does the patient have pain on forward flexion or not? And that's not a whole lot of information.
For sure. In terms of the levels, I've seen you, a few patients you treat several levels, and looking at this technique, I mean, if I'm at my clinic, I think that the ideal patient would be, for example, a 40 or 50-year-old patient with a very pristine spine, but maybe a degenerated disc, a black disc, what we used to say at L4, L5, for example, with type 1 modic changes. So that early stage that we know tends to be more painful. So that's probably the ideal patient. So even if you're thinking about anterior column patient, it's a single level, the other levels are fine. But I'm just curious if you have any limits in terms of the levels that you treat, or if you would consider this, for example, for a 78-year-old patients with advanced degenerative disc disease, maybe a Furman 4 at every single level from L1 to S1.
Well, let me just say, I would absolutely agree with you. I would love to have more opportunities to treat patients in their 40s and 50s, but unfortunately, the procedure is not yet widely covered. And so for that reason, we have not had too many of those ideal patients. You're right, those are the ideal patients. They have single level disease. They have absolutely severe and refractory lumbar pain. They have the modic changes. As far as the levels treated in the older patient population that we have been able to give access to this procedure, we have strictly used the modic changes, being present. I think it would be very interesting to study perhaps Furman grading and doing this procedure prior to the development of modic changes, and perhaps using Furman grading. Certainly, I don't think the pain starts just when the white starts to appear on the MRI. I think that the pain is very likely to precede those modic findings. But right now, the procedure is on label for 3, 4, 5, and S1. So we have certainly initially stayed with the on label. However, we have gone into L1 and L2 as well, and that's been more recent.
Have you ever had a case, and I don't know if in terms of the FDA approval, I don't personally perform this procedure, but I know, for example, for facet ablation, for facet rhizotomy, sometimes you have reinnervation and you have to repeat the procedure. So my question is the procedure even FDA approval for a redo, maybe after a few years, or have you had cases of recurrent pain that you have done a new ablation of the basivertebral nerve?
We have not yet, and that's an excellent question. I don't think it's been sufficiently studied. What we can say is that this nerve, the basivertebral nerve, is thinly or non-myelinated, and because of that, the pain relief or the ablation may be more enduring than than the type of ablations that we do for the facet joints, where the nerve is myelinated.
Have you seen any anatomical studies or maybe radiographic studies, for instance, with MRIs that show the degree of ablation of the nerves, or showing some sense how much the nerve is affected postoperatively? Because I understand this technique started with a very interesting concept of vertebrogenic pain. A very good understanding of the innervation of this specific nerve in the vertebral body. But before even trying to correlate with pain effects, is there any way to measure that this nerve is truly affected, at least anatomically, by the ablation itself, maybe by shrinking its size or as visualized in the MRI? Have you seen anything like that, or histological studies maybe later?
Well, I've seen studies in measuring the size of the ablation on the MRI after this procedure. We've seen it in our own patients who have required an MRI for whatever reason after the procedure. The procedure leaves a very distinct appearance in the vertebral body, and we even go so far as to warn patients about those findings, because if the radiologist is not aware of this procedure yet, they may confuse it with a neoplastic lesion or some other lesion. So we do definitively see the areas that were ablated. The tissue is being heated to 85 degrees centigrade for 15 minutes. So there's very clearly a mark left, a spherical mark left that we can see on the MRI after the procedure.
So tell me a little bit about those findings. I suppose maybe it's a hypointensity in the T1 and a hyperintensity in the T2, similar to the bone marrow edema that you see in superior end plate fractures and osteoporotic patients. Is that the case?
Yes. The lesions tend to be in the area where we ablate. But what I can say, and what is interesting, is that sometimes they are a little off. They are a little bit left, a little bit right of what we had lined up on fluoro, for example. I don't know why that is, but that's also been demonstrated. But yes, those are the types of lesions that we see, and they're very unusual in appearance. And so if a radiologist has not seen them, there you can imagine there's quite a bit of confusion. We've gotten a lot of interesting phone calls.
And how long does it usually take for those to subside? Have you had any? I know this is very anecdotal, but it would be interesting to see your experience on that.
I really don't know. I really don't know how long they would be present, if they would be present forever. If I had to guess, I think that tissue is going to remain abnormal.
Radiographic follow-up for this species in terms of the effects of the basivertebral nerve ablation. Tell me a little bit in terms of future research. Where do you think? I understand it is my impression that this is a promising technique. That there have been a lot of groups in several countries involved and engaged in performing this technique, but similar to several other interesting proposals we had in the past for treatment of back pain, most of which, like IDET, annuloplasty, and all those things, have miserably failed. What's next in terms of research for us to better understand the therapeutic value of this technique, or even in terms of clinical research? We had that randomized trial. We have a technique that had FDA approval. You provide the first independent studies showing, reflecting your personal institutional experience about the effectiveness of the technique. But where can we go next in order to really validate those results, and so that it can be incorporated more widely in the clinical practice?
Well, I think it would be interesting to look at patients in terms of future research randomized to basivertebral nerve ablation versus surgery, for example, versus fusion, where a fusion is felt necessary for back pain and the consideration of a basivertebral nerve ablation instead, and see what happens with back pain in the open surgery arm versus what happens with the back pain in the BVNA arm. I think it would also be interesting to look at adjacent level disease, adjacent segment disease in surgery, and perhaps before doing a revision or looking at a pseudoarthrosis from a revision standpoint, looking at a BVNA perhaps first. And as you mentioned, maybe looking at pre-modic, doing some pre-modic research to see if patients who have back pain without having modic changes yet would do well, perhaps using the Furman grade or other to determine if they would be a candidate and see how those patients do.
And I think that's a very interesting proposal. The one caveat for that is that I think the vast majority of surgeons are, and rightly are so, quite reluctant to perform any type of surgery for axial mechanical back pain, and the literature kind of supports that position. I know in the past, people were much more, especially with A-lifts, that you don't have the disruption of the paraspinal muscles. But I can tell the vast majority of patients whom I fuse, they either have, even if it's a stable grade 1, but they have neurological compression to the point that I'm doing my surgery for the radicular symptoms, and I'm fusing them because I'm removing a significant portion of the facet joint. And in that category that I see patients for whom the primary goal of the surgery is the treatment of back pain, it would be a very selected cohort of patients. I remember in my fellowship, some of the attendings, they were using bone scans, so the technetium 99 bone scintigraphy for detection of end plate changes. And there was nothing much in the literature on that. And they were selecting patients based on that and modic changes and Furman for fusions, and then indicating an A-lift, which is a procedure without disruption of the paraspinal muscles and without causing secondary back pain. And the outcome was very reasonable. So we even published an article with I call it lumbar fusion outcome score, but basically it was a score from 0 to 3, and you would, for a Furman with advanced degenerative disc disease, I would divide in Furman, the Furman grades, and we would so that would be 1 point for advanced degenerative disc disease, 1 point for modic changes, and 1 point for a positive bone scan. So those who had at least 2 or 3 points had a much better outcome for the A-lift. So I remember at that time, I was really convinced that it's not that there is no role for surgical intervention in that patient population, but definitely, even in the patients for refractory chronic axial back pain, it's still a very selected subgroup of patients. And those are the patients that probably, even before considering something like that, might benefit from the basivertebral nerve ablation. And that's one interesting study. I would be curious to see what are the results of this procedure when indicated not only based on modic changes, but based on bone scan uptake in the end plates, because I think those are the patients that usually correlates with modic type 1. But if you have increased bone scan uptake at the end plates, then I'm really convinced that pain is vertebrogenic.
Yes, I agree.
Okay. Any other message or anything else you would like to leave to our listeners?
Josh, no, I thank you so much. And we're really, at this point, we have 47 patients enrolled. I just wanted to really thank you, and I think I echo the sentiments of a lot of other physicians when we go through an exhibit hall or we're given information. Sometimes it's industry funded. We also like to have some other information, perhaps from a colleague or from someone in the real world. Hey, listen, I'm doing this procedure; it's working well. And so take this information for what it is. It's real world, but definitely. Take it in the context of the 2 level 1 RCTs, sham controlled, very beautifully done. But this is our real world contribution to the existing literature.
Perfect. And thanks for our study. Thanks for considering NASSJ as the journal for the publication. And it has been a pleasure to have you in our podcast.
Thank you so much.